We will continue that with discussion of the surgical management. And is my share is visible?
Yes.
Okay, thank you. And thank you, Professor Attar, for making my job easy. You have taken up the predominant chunk of evaluation and also the medical management, symptom evaluation, etc. I will try to focus only on the surgical part of it. As Professor Atkar mentioned, surgical management of BPH has made a revolutionary change in the past 10 years. I can present the slides which I'm going to share today for next 3 hours. To that level, so much of changes, so much of minimally invasive treatment, and even the holmium enucleation techniques have changed a lot. I've got some small videos also for few people who may not have exposed to some minimally invasive treatment, and I know about the time, so if I am crossing the time limit, please let me know so that I will remove the videos and show only the slides. My name is Mr. Dhanasekaran. I am a urology consultant from Birmingham, and I'm so thankful for Professor Atkar for this association. It's beyond the urology curriculum, and there's a good friendship, and helped me to form lots of friends in Pakistan. And I love coming to Pakistan Urology Association meeting, and hopefully this time again in 2025 we will do some good workshops, and I love to see the trainees and the junior budding consultants. Now, since we are planning to do a kind of a case-based discussion, we will just select an index patient. Index patient, by definition, is a patient who is like a box standard one, not much comorbidities, quite straightforward one. So let's select a 56-year-old gentleman with a prostate size of 80 cc. The reason I'm selecting 80 cc is a kind of a sweet number. Anybody with prostate less than 80 cc or more suitable for minimally invasive treatments like urolift, resume, iTind, aquablation, etc. Anybody more than 80 cc or more suitable for the mega treatments like enucleation with laser or TURP or open prostatectomy, robotic prostatectomy, etc. And let us assume that this patient had tamsulosin and finasteride for 18 months and failed. His PSA is stable and normal. He has bothersome LUTS with IPS score of 20 with a quality of life score of 5, which is not good. And his flow rate showed a quite poor flow rate of 8 as a peak flow, and he enjoys a satisfactory sexual life with a partner. So this is very important. Gone are the days where the TURP is the main treatment modality, where we will inform the patient that there is a possibility of irreversible ejaculatory and erectile dysfunction. Now, because of the minimally invasive treatments, we can offer the patient ejaculation and erectile function saving options. And how are we going to proceed? Now, there are some absolute indications for surgical intervention when the medical treatment fails. So the absolute indications are recurrent refractory urinary retention in spite of giving tamsulosin, finasteride, and the trial ward of catheter getting failed, overflow incontinence, recurrent UTI, bladder stones and diverticulum, treatment resistant microscopic hematuria, dilatation of upper tract either with or without renal insufficiency. As you know, if there is a dilatation of upper tract with renal insufficiency, we call it as high pressure chronic retention. And relative indication is the one where patient can't tolerate the medicines. Now, going to the gold standard TURP, I believe TURP is no more a gold standard. It is replaced by the laser enucleation of the prostate. We have 3 methods like Nesbitt's method, Alcock's and Flock's method, Moyen-Meyer's methods, and Brown's method. The slides are quite self-explanatory. I'm quite happy to share the slides with the PAUS group. I will send it to Professor Atkar and Sharif so that they can circulate among the trainees, because there are a lot of time we have spent in producing these slides. These slides will answer everything about the surgical management of the prostate, benign prostate. That's how it is made. But I'm not going to go into the detail of the surgical techniques. We need to cover a lot of ground. There is very good strong evidence to support monopolar TURP, quite age-old procedure, and meta-analysis of 20 randomized controlled trials have shown that there is an excellent improvement of Qmax, 162%, with significant reduction of IPS score, improvement of quality of life, reduction in post-void residue. Retreatment rate is only 8% and re-TURP rate is only 8.3%. And all my slides will have on the right corner is the actual source of the evidence. So when later you have this presentation loaded up in the PAUS website, you can pause and get to the original article so that you can use it in your own presentations and in your own exams also. But this monopolar TURP has its own complications. As we all know, TUR syndrome, which is quite high, but it's reduced a lot nowadays due to improved technique, and bleeding requiring transfusion is around 2.9%. Other short and mid-term complications like acute retention, clot retention, and UTI, and long-term problems like incontinence, urinary retention, bladder neck contracture, retrograde ejaculation, ejaculatory problems, and also need for reoperation. Then came bipolar TURP. Again, it's there for more than 2 decades now. The advantage of bipolar TURP is the whole circuit is completed locally, and since there is a local conclusion, there is no need for the energy to pass on to the patient's body and to the earth plate. So it becomes very safe for patients with any metal implants, patients with any cardiac defibrillators, etc. And EAU guidelines support bipolar or monopolar TURP for prostates between 30 to 80 cc. All the evidences were quite latest 2025. Then we have bipolar transurethral vaporization of prostate. As you all know, sometimes the bipolar, we have the electrode, which is like a button-shaped electrode, which we can use to vaporize. Again, an excellent procedure, but again, not suitable for very large prostates where the resection is always better. There is a good support from the EAU guidelines 2025. Then getting further into vaporization of the prostate, we have the laser-based vaporization, like for example, thulium, yttrium, aluminum garnet laser. These vaporization procedures are quite good. Again, they are all very suitable for patients with any bleeding diathesis or patients who are taking any anticoagulants. It takes quite long operation time to vaporize the tissue. With good resectionists, they will feel vaporization of the prostate is not enough. Transurethral incision of the prostate, which is the correct nomenclature for the simple word bladder neck incision. We keep it reserved for high bladder neck and prostates less than 30 cc. If the prostate is quite small, transurethral incision of prostate has a good improvement. And now, getting into the main chunk, like holmium laser enucleation of the prostate. So these are all now going to be the gold standard. I know that enucleation of prostate is not very widespread in Pakistan institutes when I visited for the past few years. And I was just talking to Professor Atkar before starting of this CME that maybe in this year, PAUS, we should do a dedicated workshop on how to do an enucleation of the prostate by using the laser. And believe me, if somebody has done hundreds and hundreds of TURP, after starting the enucleation, they will feel, why I have not started this enucleation long back. It gives you absolutely one of the greatest possible capsule. It preserves the anatomy. The bleeding is less than TURP if properly done. The only challenge is the learning curve. You need to do at least 20 to 50 patients in a very supervised manner so that you will become a confident person and you can start teaching others. And the enucleation of the prostate has become now the standard of art. The same enucleation can be done by other lasers also, for example, thulium laser. I find the thulium laser is slightly difficult to handle because it doesn't maintain that capsule gland margin. So it tries to cut the gland, so sometime you will be lost. And holmium learning curve seems to be slightly easier compared to the thulium laser learning curve. Again, multiple meta-analysis supporting both, and I've listed all the important studies in the picture. EAU 2025 latest guidelines have very good support on the laser enucleation of the prostate. And the so-called green light laser, not very famous in Asian countries, but in the Western world it's quite famous because it is one of the first technique which tried to preserve the ejaculation. And we got multiple studies like Goliath study, which clearly proved that this kind of vaporization has a good role in creating the good channel. But once we started having much better minimally invasive treatment, like for example Eurolift, Resume, iTint, etc., the green light vaporization has lost its favor, I will say. And there's good support from EAU guidelines 2025. Coming to the minimally invasive treatments, the first one what we are discussing is known as Resume. It works by the principle of convective water vapor therapy, where the water vapor is used to kind of create a natural apoptosis of the prostate tissue. A thin layer of a needle was inserted into the prostate under the vision, and water is injected, which is a steam, for 90 seconds. The water causes the apoptosis of the tissue, resulting in very, very good channel. We have got now results spanning up to 8 years and 9 years. This is the 5th year result from McQuarrie et al., which showed excellent improvement of IPS score and quality of life and improvement in the uroflowmetry parameters. Nicely supported by all the guidelines, including NICE and also the EAU guidelines. So this is how it will work. There is a generator with an applicator, and the applicator has got a needle, and once the needle is appropriately used, you can see that the whole prostate gland is nicely apoptosed. So this is the gland with a good median lobe, and this is the 6-month post-treatment. You can see the channel achieved. The amount of channel produced by Resume is quite satisfactory. The only disadvantage is Resume after treatment causes temporary swelling of the gland, so patients should need a catheter immediate post-op, and the catheter can be removed in 5 to 7 days. Some patients who never had catheter before don't like it. That's one big disadvantage of the Resume. I have videos for Resume and aquablation and everything. In fact, last time when I came for the PAUS 2024, we did a 2-hour workshop on Resume, and I'm glad to see that a lot of places in Pakistan have started using Resume. I would love to hear the feedback on how the program is going on. The new technique, aquablation, is now quite famous. Initially started in US, and now across the Atlantic, across the Europe, many centers have started using the aquablation. It uses a technique of high-speed water jet, where the water jet is used to create the channel, and it is appropriately visualized by cystoscope and also by a transrectal ultrasound. And there are many evidences to support that, like water 1 trial, water 2 trial. I'm not getting into the details of the trials, because at the end of the day, all the trials are saying that the evidence is very supportive of the energy what we are discussing. And it's approved by the EAU guidelines 2025 and NICE guidelines 2023. And so this is how it will work. When you are seeing the cystoscopic view, this is the aquablation, the probe, and the probe works almost like 270 degrees, leaving only a small amount of tissue in the anterior commissure. And here you can see kind of an animation which shows how the gland is nicely vaporized, and the treatment is so sleek. You can see it in real time. And now we do a program where we run this 2 times so that the cavity produced is quite good. And this is the robotic equipment which is used for the delivery of the aquablation. The aquablation technique is quite versatile, can be used to small gland as small as 30 or 40 cc, and can be used even up to 150 cc, quite large glands. So it's like a one technique which can stitch anybody. And while the smaller ones are for minimally invasive treatment and larger ones for enucleation, aquablation will create a good kind of a level playing field for everything. As I said, multiple publications, water 1 study, water 2 study, and open water study. All the studies have proven that the aquablation has got a good place for long-term outcome. This is how the setting will be. You will be able to see that the delivery by aquablation probe, and there is a transrectal ultrasound. So you'll be able to see the transrectal ultrasound picture showing how the ablation is happening, and a cystoscopic picture also showing the level of ablation. And these are all the settings for the aquablation. Wonderful procedure. quite costly to set up in a developing country, and but at least maybe Professor Atkar units or 1 or 2 units should be able to affordably get it, and it will be a wonderful instrument to have for any size of the gland. That's the main advantage of it. And so this is how it will look during the procedure. You can mark and preserve the bladder neck, you can mark and preserve the sphincter, and intraoperatively you can see that the amount of gland which is nicely ablated by the water jet. This is the gland which is ablated now, and in 3 months post-op you can see a wonderful, smooth, nice, large cavity. And heading towards the other energy sources, prostatic artery embolization. It's not something a urologist armamentarium, but it's very good for somebody with interventional radiologist, where they can use the embolization technique to embolize the prostate. Very good technique for quite frail men who are not fit for any procedure, heavy bleeding from the prostate. We are blocking the prostatic artery, so indirectly the bleeding will get sorted, and we can do it as an outpatient procedure without any need for anesthesia. Good amount of randomized studies, especially in UK. We have ROPE study which was published in 2018 showing there is a big role, and AAU 2025 and NICE guidelines in 2018 have supported it. So this is how it will work. The access is either through a radial artery catheterization or a femoral artery catheterization. The aim is to reach the prostatic artery and use the embolization beads for the glands to get shrunk and kind of creating a good cavity. Not a urologist armamentarium, but if you have a frail patient who is not fit for even a haircut, this procedure can be done as a day procedure. And the prostatic urethral lift, I think last 2 times when I attended PAUS, I made multiple presentations on prostatic urethral lift. A very good technique, gives you a lot of satisfaction because you are doing something quite actively to produce the opening of the glands, applying the urolift in multiple places to creating the channel. I can see there are 2-3 places in Pakistan already started doing it with very good results. Hopefully in 2025 we may be able to do a workshop on prostatic urethral lift for training some senior consultants. Can be done under local anesthesia. Again, there is a very good support from the NICE guidelines. There are multiple evidences, multiple publications, very excellent preservation of ejaculatory and erectile function. This is one technique where we can assure and say that patient's erection and ejaculation will be as it is before the surgery. This is the only procedure, even compared to resume, where the chances of injuring an ejaculatory duct or a nerve is almost nil. And multiple studies, BPH6 study and Pulsar study. Pulsar study is the one which clearly proven that the prostatic urethral lift can be done even for acute detention patient. And there is a Cochrane review from May 2019 proving the importance of the study. MedLift is the one where we can use the urolift in the obstructing median lobe, and Pulsar study, as I said, is for the acute urinary retention. It has some minor complications like hematuria, pelvic pain, urgency, but most of the complications are quite self-limiting. And we can offer prostatic urethral lift as per the NICE guidelines or the EAU guidelines. I will try to show a kind of a small video because some of you may not have exposed to the one. I will share it. Just give me 1 minute. I hope my video is shown, isn't it?
Please. Yes, we can see the screen.
Thank you. So the video is now running. So you can see this is a 69-year-old gentleman with a very occlusive prostate. I'm not selecting a very juicy small prostate. It's a very occlusive prostate, very suitable for TURP or HOLEP, but there is a good possibility with the help of the prostatic urethral lift. By creating a good compression with multiple implants, we can create a good channel. So this is the first left mid-gland implant. You can see how much a surgeon can give the compression to fire the gland and create that opening by using the implant. And once there is a white line reflection, you can see even now how much the gland is now nicely open. And we can do the same thing again on multiple places on the left side because it's a very, very large gland. I don't want to show a very small gland with a prostatic urethral lift just to prove that the technique is possible. The technique is definitely possible for any glands up to 80 cc and also for a median lobe. Now we are doing the right side. You can see again a very nice compression, and the implant really opens up the gland. And the advantage of this is that whole procedure can be done as a day procedure. It can be done completely under local anesthesia. There is no need for any anesthesia, so very suitable for again very frail patients who may not be having the advantage of having any anesthesia. And now I will show the outcome. This patient required 4 implants, and you can see that the outcome is a nice good channel, and this channel will further become bigger and nicely modeled. You can see the channel compared to the previous occlusive one. And okay, I will go back to my presentation. Okay, there are some other not well established techniques, like for example intraprostatic injections with the help of botulinum toxin, and few other newer techniques also available. I will say this more for completion for exam going PGs, just when they are answering all the questions on surgical management of the prostate, and if there is a last question which the examiner asks, okay, do you want to know or do you aware of any most advanced or most recent updates in the prostate treatment, they can just bring it on with the intraprostatic injections. Again, I'm not a very fan of it because we are surgeons, we want to do something to create a channel, not by just injecting the medicines into it. And iTint is a very simple technique where we will pass a 3-pronged metal suture, which is a kind of an implant which will open up the bladder neck. Very good for a bladder neck only obstruction, or maybe a prostate up to 40, I will say not more than 50 cc. Approved for nice guidelines for the initial setup, but we need to be very mindful. It is not a good procedure for very large obstructive juicy glands. I have a video, I will try to share it because it will be quite interesting for again those who have not come across it. And this is an animation video where you can see that the penile urethra is straightened, and with the help of the cystoscope we are able to go in and have a good diagnostic look. And with help of the cystoscope, under the guidance, under the visual appearance, we will put the iTint implant into the bladder. And as I said, iTint implant has got like 3 prongs. Adjust the size and position quite appropriately in the bladder, and slowly take the iTint back into the prostate. So it creates 3 cuts at the level of 12 o'clock, 5 o'clock and 7 o'clock. It's almost like a bladder neck incision, but the advantage is there is no energy, and we are doing it completely under local anesthesia. And if you have good experience, you can do even under flexible cystoscopy in a day unit. You can see that how when the implant comes into the appropriate place, it creates a small opening. When we leave this implant for 5 to 7 days, slowly the implant opens up the prostate further, creating a nice good channel. Patients do tolerate them okay. I won't say patients will be quite happy in the initial days, but when the 5 days goes on, as you can see that the implant is nicely creating a nice 3 cuts. It produces a very nice big opening of the bladder neck, and it does cut the prostate maybe up to 30 to 40 cc, maximum of 50 cc. And the device removal can be done under local anesthesia, where an open end catheter is passed into the suture, and the whole gland is brought into the open end catheter, and the whole device can be removed in toto. Very straightforward technique and very minimally invasive technique. I will reserve it for very, very, very small glands. You can see that the amount of channel it produces. And if you ask me personally between UroLift, Resume and iTint, I will certainly say UroLift and Resume will have a better outcome and better channel compared to iTint. But it's nice to know the various other possibilities also. And I will try to continue the slides. So we have finished with iTint. And there are some metal implants available, like for example allium stent, where this is the allium stent which is kept, and it has got a small area for the external sphincter and a small area in the bulbar urethra to prevent its migration. Again, a very good option for very old frail patients. And other options available are equivalent to the source of radical prostatectomy. There are some institutes where radical prostatectomy by using robot is well established, so they have just extended it to see why can't we use the same robot to do the simple prostatectomy also. So robotic assisted or laparoscopic assisted prostatectomy is well established, especially in America, where the tariff is quite good and quite high. But no wonder, if somebody is quite trained in radical prostatectomy, especially with robot guidance, they can do the same thing, simple prostatectomy. Now the advancements have gone to the level of a single port robotic simple prostatectomy, transvesical, and many publications have come. And with the help of the whole beam enucleation, we are able to treat the gland even up to 300-400 cc. So this robotic prostatectomy will be handy in case if there is an unfortunate patient with 500-600 cc prostate. And open simple prostatectomy, again, I'm not an experienced in that. I've not done much open prostatectomy after my training days, and like how Professor Akhtar was saying in the start of the talk, open prostatectomy, open cystectomy, possibly we may have to call Professor Akhtar to train us. And the procedure is so good, but the same procedure is now replaced by robotic assisted, as I said, and also by transurethral by using the whole beam enucleation. So the principles are same, it's only the methodology is different. I will complete my talk with a couple of very good articles. This article is from British Medical Journal, which compared the efficiency and safety of the new surgical equipments, and it clearly said that whole beam enucleation really outperformed all the minimally invasive methods. So if the patient wants a kind of a lifelong assured outcome, and if the gland is on the larger side, try to go for a definitive surgery. And this is a kind of the scheme what we have, and we always examine the patient, find the diagnosis, discuss all the treatment options, and decide on which treatment patient needs based upon the size of the gland, based upon the patient's ejaculatory and erectile function, and size of the prostate with outcomes. And the single slide itself is quite useful for those who are writing any exams or going for the Viva exams. This is a very hot publication just only 2 months back, where the surgery done for the benign prostate, especially in England, it studied the kind of a population-based study. You can see that from 2012, from 10 years up to 2023, the TURP is showing a slight decrease, and there is a definite decrease in the TURP, while the other technologies, especially the whole beam enucleation, is showing a very good improvement. Thank you very much. I tried to make a very comprehensive explanation of the surgical management, which every modality we can speak for an hour, and I hope it's useful, and I'm happy to receive any questions.
Thank you very much, Ananda. As always, a very comprehensive talk in a very short period of time. I'm sure that our audience will be very keen to learn from you in person during the forthcoming PAUS Annual Congress in November this year. There are questions about which modality. I'm actually finding the 2-3 questions that we had about which mist is not indicated for median lobe.
Yeah. Regarding median lobe, what we need to understand is a lot of patients with median lobe is maybe the main chunk causing the problem, because lateral lobe is just a bystander causing the obstruction, while median lobe really blocks the urine outflow head on. So if there is a good chunky median lobe, I will say don't even think anything, plan for only TURP, if not laser enucleation. These patients will have very satisfactory outcome. But having said that, if somebody wants to do a minimally invasive treatment only, we have only 2 options. First is Urolift, second is Resume. Both are quite good. While doing Resume, we need to inject the water vapor in the median lobe and treat the median lobe. It will get shrunk. And for Eurolift, as I showed, the mid-lift study, where we can use an implant to treat the median lobe. The other minimally invasive methods are not suitable for median lobe, but if there is a patient, I will give more importance to a gold standard TRP or the new gold standard whole meme enucleation compared to any minimally invasive treatment.
Thank you very much, Ananda. I'm sure that there are questions, and I can see a lot of questions. Unfortunately, there is another session starting on uro-oncology at 8 o'clock Pakistan time. If it is okay, I can share. Sharif can share your email address.
Sure.
For these. Okay, great. Thank you very much.
I am in the POUS WhatsApp group, so if any questions in the WhatsApp group, I'm quite happy to answer.
Yeah, so if you can just post these questions to Dr. Mr. Dhanasekharan, he will be very, very happy. He loves teaching. So this is his passion, and his commitment is really commendable. So thank you very much, Ananda, once again for